Look, good afternoon. My name is Jenny May and I'm here to give you a quick run through on the Healthy Heart Check. Look, I'd like to start this afternoon by acknowledging that I'm speaking to you from Tamworth here on Gamilaroi country and pay my respects to the traditional custodians of the land and to elders past and present. But I also want to extend that acknowledgement to Aboriginal and Torres Strait Islander people who might be listening to this presentation. And certainly the Healthy Heart Check has huge implications for improving or making visible risk factors, and Aboriginal and Torres Strait Islander people who live rurally have every reason for us to do that and to do that to try and reduce their overall risk factors and improve their health outcomes. So moving right along, who can we do a Healthy Heart Check on? Well, really importantly, the item number that you're going to be charging, and we really need that, is a 177 if you're not vocationally registered, or a 699 if you are vocationally registered and able to charge that particular number. Now, what is the Healthy Heart Check and who can use it? So the good thing is that it can be used on anybody over the age of 30. And it needs to last about 20 minutes. It leads to, as I've written or taken from the MBS descriptor here on the screen, involve the collection of relevant health information, including a patient history. It needs a basic physical examination, which must include recording blood pressure, cholesterol, and I always include a blood sugar. It requires us to initiate interventions and referrals as appropriate, implement a management plan, and provide the patient with important preventive health information, and possibly, in the way I do it, a written healthy heart plan. So there's lots of things out there that we can use to assist us in this process, but the important things that you need to know are you claiming this for the first time in 12 months? Because if you're claiming it for a second time or someone else has claimed it in the last 12 months, don't bother, because MBS will only pay, or Medicare will only pay, if it's done once in a 12-month period. It's important that you're either the patient's usual medical practitioner or you come from the same practice and it is agreed that you are the most relevant and appropriate person to do it. And it is advisable, and obviously part of the continuity of care that we are considering in a Healthy Heart Check, that you will provide the majority of healthcare to that patient over the next 12 months. So that's lots of patients, and it's a really worthwhile thing. So there is a couple of pieces of planning that I absolutely want to commend to you, because certainly as I've embarked upon doing these, I found this makes it much easier. So what I do is, prior to doing the Healthy Heart Check and planning on charging that item number, that MBS item number, in my case 699, I order the bloods. So I make sure that I've got that lab form to the patient for at least a couple of days prior to the consultation. So what do I order? I always order electrolytes, liver function tests. I look at diabetic risk by ordering a HbA1c and a random blood sugar. Really importantly, we do a fasting lipid profile. Make sure that it doesn't just include a total cholesterol, but it gives you an HDL and an LDL. So I always write HDL-LDL-total cholesterol, and clearly a triglyceride is useful. Most importantly, you need a microalbumin. There are reasons for regarding people as moderate to high risk that are more than just their lipids, and a high urinary microalbumin in the presence of either diabetes or of hypertension is another very good reason to worry about relative cardiac risk. So you've done those things, and at the consult, I want you to have a pen and paper or an electronic way of recording blood pressure, weight, height, BMI, pulse, and they ask for waist circumference. I don't routinely do waist circumference, but it's there. Now, some people ask me, what about an ECG? And certainly if there are risk factors that you are aware of prior to doing your heart health check, then there is every reason why you might include an ECG. Now, if the relative risks that the patient comes with and the history is not well known to you, then you may well to choose it to do it as an intermediate step. But there's an argument for including and there's an argument for not including routinely. We leave it up to you. So you've identified you're going to do the patient for the heart health check, you've ordered the bloods. Prior to embarking on the forms that I'm going to show you in best practice, what I want you to do is to go into their record and have a look at the cardiovascular risk calculator. The reason I'm suggesting is that as part of that healthy heart check or that risk assessment, they often ask for the risk. So if you punch your numbers in advance, then you can easily do it by having that information in front of you and putting it in. Otherwise, you've got to go out of that document, back into that part in best practice and out again. So this is my hot tip for how to do it efficiently. So I've just put in there, you know, a fake patient whose systolic blood pressure was 150, whose total cholesterol is 8.2, whose LDL is high, you'll notice at 2, who doesn't have left ventricular hypertrophy on an ECG. And I might have ticked that because I didn't do it, but I obviously clearly at that point thought that they were low risk of having an ECG changes, but noted that they were diabetic, a very good reason potentially for having done an ECG and looked for left ventricular hypertrophy, and clearly this person has smoked. So you can see coming up with a probability of 10%, which is in the moderate to high risk range. So you've got that, and then we go into best practice and get hold of the 2 documents that we're going to use as part of that healthy heart check. So we go up, and as you know, when we can add to our template favourites, so under those templates that are available through best practice, you'll see, and I put a red arrow there for us, to the CVD risk assessment form and the heart health check, my healthy heart plan. Now they are the 2 heart foundation forms. There are other templates that you will notice in best practice that you could use, but for the interests of brevity and control, I'm going to show you those 2 forms that I tend to use, the CVD risk assessment form and the healthy heart form. So you add those, as you know, to your templates for easy access. Now, if you embark on the first form, which is the risk assessment, the nice thing is that some fields from best practice dump straight into this risk assessment. And you can see here that if the patient was on medication, it would dump straight into the template. You can see that I've ticked blood pressure, height, weight, all those things that I mentioned before, and I've ticked some that I don't really need, but I've ticked them all because if they're there, we may as well insert them. And I've put a record range there of a year. I think that's reasonable. If you can only do a heart health check once a year, I think gathering that data from the last year is not unreasonable. So that will insert into your template. As you walk through the template, I'm walking through the template now with the patient in the room. So I've brought the patient into the room. I've got those lab tests, which I've either printed off or I've got those salient results in front of me, separate from, again, trying to find them in the file. And then with the patient, I walk through this. Really interesting, some of the things that are in there and some of the things that aren't. We know that hypertension during pregnancy is a risk factor for ongoing hypertension. So that's a really important question to ask. You can see that the urinary microalbumin measurements are in there and expected for you to type those in. You can see that the form asks about atrial fibrillation and left ventricular hypertrophy. So clearly, as I said, if the patient is diabetic or there is any predictive reason that you would think that they may be abnormal, then you would need to have done your ECG and therefore be able to tick those boxes. Interestingly, as you go down this form, you get plenty of family history, really important. You get an assessment of their smoking risk, and then you get some interesting comments about diet. And I bring this to your attention. It asks at one point in the form, describe your diet. And I put in, you know, what a patient said to me. My diet's great. Now, what does that mean? So importantly, it does talk about number of portions of fruit and vegetables, and clearly self-report is only one part of doing this heart health check. Exercise, similarly, they can identify the sort of exercise they're getting, and we know that the intensity or aerobic nature of that exercise is important, and so we will make those judgments. And you can see that I've got that red arrow showing you the numerous spots where you're going to put in those laboratory measurements that you got. Okay, so all those things dump into this, but you can see the reason I asked you to get that CVS risk calculator before is now you've got to put it in. And you can see that at this part of the form, you're also putting in a whole lot of things that you've already gleaned from the form before. So it's not my usual practice to download this document or print it out for patients. What I usually do is to do it in the form of a plan. But in this form, you can start to see you talking as the GP, talking about what the goals are. And you can see towards the bottom of this that you're asking what your blood pressure goal is for this patient. So clearly this patient is diabetic. So I'm very interested in making sure that that blood pressure reading is 130/80 as opposed to something 140, 85, which I might accept for a non-diabetic. Yes, I have it here, yes. Bottom half of that second photo, you can see patient is clinically determined high risk of CVD if they have diabetes and age greater than 60, diabetes and microalbuminuria, moderate or severe chronic kidney disease, and there is another one on the, here we are, previous diagnosis of familial hypercholesterolemia, systolic hypertension, or a serum total cholesterol greater than 7.5. So you might have calculated their risk, but those conditions also make them moderate to high risk of heart disease. Okay, so we've done the risk assessment and we've identified that they are moderate to high risk. So we go on to the next form. Sorry, that was just what I just said. And here we are with the take-home plan, which is that second document. Now, the take-home plan really encapsulates a lot of what we've gleaned in that first risk assessment document, but tries to make it a much more usable thing for the patient and is really your implementation plan with your strategies to try and reduce their risk. Now, if we work through it, what we are doing is marrying, as I said, their current situation with what you're aspiring for to reduce their risk. And you can see, again, that having your list of labs sitting there on the left, that, on your piece of paper, where you can type them in is really useful. And on this particular healthy heart plan, the good thing is that there are the appropriate goals sitting on your right. So if you've forgotten exactly what the LDL target is, then you can pop it in. So this patient who's diabetic and who we've decided is moderate to high risk, clearly their blood pressure is too high for their current scenario. So this is the trigger for me to consider what is the tailored advice that is consistent with their condition that I'm going to give them to try and reduce their risk. So clearly in this situation, I'd be considering a blood pressure lowering medication, and you can see at the top of the form, there's what you might put in. Clearly you would consider in this patient who's diabetic a cholesterol lowering medication, and clearly you consider lifestyle goals. Now, obviously there are multiple potential ways to skin this cat, and the way that you go about the motivational interviewing and engaging the patient in this tailored advice is very much coloured by your experience and your expertise and what you know works in your patient population. In general, I suggest that you set realistic goals. Certainly dealing with my patients, I tend to do goals sequentially. If I hit someone with 5 different goals at once, I find it hard for them to process it all and make it come through. So often we will prioritise important goals. Now, the Heart Foundation gives us some really helpful hints here on the left, but it is absolutely your bag as to what you put on the right and make those priority health goals. So often with alcohol, I do talk about non-alcohol free days, I talk about limits, I talk about ways of limiting alcohol. If someone's overweight and they need a dietetic or a nutrition intervention, I usually start with portion size, salt restriction and goal weight, but I don't expect that they'll do all of them at once. And clearly this is the time when you should be considering tailored referral to allied health professionals and others who can contribute and support this patient's long-term management of their goals. The nice bit about the form is that although it might be seeming quite prescriptive, it does act as a prompt for both a dietetics intervention, an exercise intervention and a helpline. And certainly I lean on local. So often our practice nurses or our practice colleagues know much more about what's available locally from the exercise point of view, where there's easy or gentle exercise. And just remember that in goals, what you're looking for is an incremental increase or getting people to walk a bit and then a bit more and then a bit more, rather than telling them that they have to walk 15,000 steps a day. The other thing is, in terms of both nutrition interventions and other interventions, clearly doing this sort of check is the segue into, in our case, the Healthy Heart Study, which is running in most general practices in our area. And this forms and the uploading of these forms will form your referral for your patients into that study, with the opportunity to have access to an intervention either now or in the future. Secondly, you may choose to send them to an exercise physiology. If you have diagnoses that can be regarded as chronic and lasting more than 6 months, there's obviously the opportunity to key them in through a team care arrangement and a GP management plan into further allied health professional visits and supports. But hopefully what we've done is just walk you through briefly a way of accessing those forms, considering how you fill them out, and a few quick tips about how not to have to reinvent the wheel and go back in and back out. But importantly, more than one way to skin this cat, and you may well develop over time your own very specific forms and arrangements that work really well for your patients. Just as an aside, doing it this way and right now is really helpful from the point of view of allowing people to be accepted into the Healthy Heart Study, which of course I would affirm. Thank you very much for your time.